Hello, everyone, and welcome to today's webinar on EDI and your practice. My name is Allison Whitenack. I'm a Senior Policy Officer on the HCPC's Policy and Standards team, and joining me today is Dabbi Taylor. Dabbi, would you like to introduce yourself?
Hello, everyone. My name is Dabbi Taylor. I'm an occupational therapist working in child and adolescent mental health in Glasgow.
Thank you so much, Dabbi, and thank you all so much for joining us today. So before we begin, we have just a few housekeeping bits to help you get the most out of your time today. So our session today is 45 minutes long, and due to the large numbers that we have in attendance, microphones and cameras are turned off. We do have a Q&A function today, which is being moderated by our colleagues in the communications team. So you can click the Q&A button to access that, and it's open for your comments and reactions, which you're welcome to make. But sadly, we won't be able to answer questions today due to just the scale of the event. In terms of certificates, we don't issue certificates for our events, and we don't assign CPD points either. But this session can be used as a part of your CPD if you reflect on what you've learned in an appropriate way, and if you provide evidence of your attendance. You can find out more about that on our website. And a follow-up email will be circulated after the event, which will include the slides, the recording of the session, as well as some useful resources. And then finally, we do have an interactive tool that we're using today called Slido. And we'll be using that in just a second, and you can use that by using your phone or a separate browser tab. You'll just need to scan a QR code or go to slido.com and enter a code. And your responses to that will be anonymous by default. So just to quickly go through the agenda for today. So of course, we're having our introduction right now. Then we'll quickly go over what EDI is and what it means to us as a healthcare regulator and what it means in healthcare settings. And then we'll go over the HCPC standards and how these relate to EDI. We'll then move into our case study with Dabbi, and he'll talk about applying EDI in his practice. And then we'll kind of circle back to building your EDI knowledge, so how you can learn more moving forward, and conclude the session. So here is our first Slido question for the day. So if you could scan this QR code, or again, in a separate browser, go to slido.com and enter this code that you see here, and rate your knowledge and understanding of the webinar topic. Of course, the webinar topic today is EDI and your practice. So we'll just give folks a few minutes to rate that on a scale of 1 to 5. All right, we're getting some good votes in now. Looks like we've got quite a range, but people are kind of looking towards the middle. So 3 out of 5 stars. Some people on kind of the either ends of the middle. All right, I think we're going to move on, but definitely keep voting. It's really encouraging to see some folks who are in the kind of 4 and 5 stars. But it's also great to see that people have a lot to learn, and hopefully some of you will feel more confident by the end of this session. So just a reminder, as it is CPD week, let's do a quick grounding in CPD and why it matters. So we, the HCPC, are a regulator of 15 health and care professions, and our purpose is to safeguard the health and well-beings of persons using or needing the services of our registrants. In other words, to protect the public. Our role is to make sure that registrants, you all, are practicing safely and effectively. And one key part of ensuring that is ensuring that your knowledge and skills are up to date, and that is done through continuing professional development, CPD. CPD is specific to you and your scope of practice. It is outcome-based, not based on points or hours, and it is self-directed and self-managed. Reflection is an essential part of CPD, and that means appropriate reflection, so where you consider the benefits of CPD for your service users, your practice, and your future career. Reflection is really how you embed your learning. And you can read more about the CPD requirements on our website. You can follow this link here on the slide. So today we're talking about EDI and your practice. But what exactly is EDI and how do we as a healthcare regulator describe it? So we have some information about EDI on our website, which you can find at this link here. But equality means treating people fairly in a way that reflects their needs, ensuring they have equal opportunity to achieve their desired outcomes, and eliminating discrimination. Diversity is about valuing individuals for the different perspectives they have to offer and maximizing the range of voices who can contribute. And inclusion means ensuring that everybody has a voice and a means to participate. And this may involve making reasonable adjustments to our usual processes. Under the Equality Act of 2010, we have a legal duty as a public body to have due regard to the need to promote equality of opportunity, eliminate unlawful discrimination, and foster good relations between key equality strands. And these strands include age, disability, sex, race, religion or belief, sexual orientation, gender reassignment, and pregnancy and maternity. Part of how we fulfill our legal duty is through our key regulatory functions, and one of those regulatory functions is setting and maintaining standards for the professions that we regulate. For the HCPC as a healthcare regulator, EDI is the framework that we use to ensure that our work as a regulator is fair. For you as a registrant, EDI is not only something that we as a regulator expect you to consider in your practice, but it is also a framework that you can use to help make decisions and provide the best care in the course of your difficult jobs. So we know that our registrants work with an increasingly diverse population, and part of our role is ensuring that the healthcare workforce can meet the needs of a 21st century UK. For example, the population is aging, which brings huge changes both in the number of people requiring access to services, but also the nature of the care they need. There is a growing awareness of health inequalities and health outcomes that differ across groups. So our registrants need to be equipped to meet these health needs and tackle the causes of health inequalities. As well as ensuring that registrants have the knowledge to meet diverse health needs, we are also clear that a registrant who unfairly discriminates is not safe. We know that EDI is actually a public safety issue. It is not an add-on or something that is simply nice to have. So now that I've explained a bit about what EDI is, what those different terms mean, and kind of how we approach EDI as a healthcare regulator and in healthcare settings, we're going to move into talking a bit more about the HCPC standards and how they relate to EDI. So we'll be talking about two of our sets of standards today that directly relate to registrants' practice. So we have our standards of proficiency and the standards of conduct, performance, and ethics. And you'll see that I have pictures of both of these standards here, and I have the example from the dietitian's standards of proficiency on the screen. So the standards of proficiency are the threshold or entry-level standards that we consider necessary to protect the public. These are the expectations that we have of our registrants' knowledge and abilities for when they start practicing. And once on the register, the standards of proficiency offer flexibility in that as registrants continue on in their practice, they must continue to meet the standards of proficiency that are relevant to their scope of practice. The standards of conduct, performance, and ethics set out how registrants ought to behave. They outline what the public should expect from health and care professionals, and they help us at the HCPC make decisions about the character of people who join our register. We can also use them if someone raises a concern about a registrant's practice or when things go wrong. The standards of conduct, performance, and ethics are outcome-focused rather than prescriptive, so that means that they tell you what we expect in active language, but they don't tell you how you need to meet the standard. This means that the standards are also a tool for you in your practice and can help you make and justify your decisions. And this is a good thing as it gives you autonomy and flexibility to practice in the way you need to. How to meet the standards and what is and is not appropriate will depend on the circumstances of your individual practice and the context in which you are working. And that is often why we say you need to use your professional judgment to assess what is safe and effective practice in the context in which you are working. When it comes to the standards in EDI, we have several standards that connect more directly to EDI and set out what we expect from registrants when navigating the diverse needs of their service users and the increasingly complex healthcare setting. But taken as a whole, the standards provide a really useful framework for understanding the knowledge that you should have and then how to translate that into actions in your practice. So as I mentioned, there are some standards that relate specifically to EDI, which we'll go over now, and we'll start with the standards of proficiency. So Standard 5 of the Standards of Proficiency is all about ensuring that registrants recognize the importance of EDI in health and care. In Standard 5.1, we set out that registrants need to respond appropriately to difference and to recognize that service user needs can be affected by any kind of difference. Standard 5.2 sets out an expectation that registrants should understand equality legislation, for example, the Equality Act 2010, which we discussed earlier. And Standard 5.3, we highlight values, beliefs, and personal biases and their impact on practice. So this reflects our position of expecting registrants to take positive action to understand and reflect on their own assumptions and consider how this may impact on the way they deliver care. You'll notice that the terminology used in the standards highlights taking action rather than simple passive knowledge. For example, for registrants to recognize the impact of culture, equality, and diversity, and actually practice in a non-discriminatory and inclusive manner. Continuing on with the standards of proficiency, Standard 5.4 focuses on reasonable adjustments and aims to tackle barriers to accessing health and care that service users may experience. Standard 5.5 sets the expectation that registrants actively consider the causes, indicators, and consequences of barriers to inclusion, which also helps to expand beyond just disability-related adjustments that may support everyone to engage. Ensuring that registrants take action to challenge these barriers is covered by Standard 5.6, and Standard 5.7 reminds registrants to read the standards of proficiency in their totality and to see the ways in which the standards interact with each other. For example, there are clear examples of EDI mentioned in the leadership standards, in the standards of proficiency, and there are clear threads of equality, diversity, and inclusion running through several other themes in the standards, especially relating to centralizing the service user in care. And just like in the standards of proficiency, the standards of conduct, performance, and ethics use active language for registrants. There are 10 high-level standards of conduct, performance, and ethics, and Standard 1 is to promote and protect the interests of service users and carers. This includes challenging discrimination. So Standard 1.5 says that you must treat people fairly and be aware of the potential impact that your personal values, biases, and beliefs may have on the treatment, care, and other services that you provide to service users and carers, and in your interactions with colleagues. Standard 1.6 emphasizes that you must take action to ensure that your values, biases, and beliefs do not lead you to discriminate, and that your personal values, biases, and beliefs must not detrimentally impact the care, treatment, or other services that you provide. And Standard 1.7 indicates that registrants must raise concerns about colleagues if you think they're treating people unfairly or if they are discriminating against service users, carers, or colleagues. So something important to note about the standards of conduct, performance, and ethics is that they are also all interrelated. That means that to meet a standard, you often have to meet others to do so effectively, and that many standards may be relevant at once. So, for example, to meet Standard 1.6, registrants need to be aware of the potential impact of their personal values, biases, and beliefs on the services that they provide, which is Standard 1.5. Simultaneously, to treat people fairly, Standard 1.5, registrants may need to take action, Standard 1.6, or even raise concerns, Standard 1.7. So it's important to look at all 10 of the standards of conduct, performance, and ethics together. So as I mentioned, Standard 1 requires registrants to promote and protect the interests of service users and carers, which also includes a duty to maintain appropriate boundaries. So Standard 1.8 requires registrants to consider the potential impact of their position of power and trust in social and personal settings. Similarly, Standard 1.9 requires registrants to take action to set professional boundaries with service users and carers and also colleagues. Standard 1.10 requires registrants to use appropriate methods of communication in their provision of care. Standard 1.11 makes it clear that registrants must ensure that any personal relationship between colleagues should not influence a registrant's professional decisions. And Standard 1.12 refers to registrants not abusing their position and sets out the specific types of relationships that registrants should ensure are not founded upon an abuse of their power. This includes personal, sexual, emotional, or financial relationships. So let's quickly revisit our definition of EDI to better understand the connection to these standards. So equality being treating people fairly in a way that reflects their needs, ensuring they have equal opportunity to achieve their desired outcomes, and eliminating discrimination. Diversity being about valuing individuals for their different perspectives and maximizing the range of voices that can contribute. And inclusion meaning ensuring that everybody has a voice and a means to participate, which may include making reasonable adjustments. So with these definitions in mind, we can see how these standards to maintain appropriate boundaries might require EDI considerations. For example, in Standard 1.8, how might the position of power and trust you hold as a healthcare professional impact your service users differently? For example, if they are a refugee or otherwise particularly vulnerable. Or in Standard 1.10, how might you need to adjust your methods of communication to be appropriate and inclusive for service users if they have a disability that impacts their speech or hearing? These standards also connect to the Equality Act protections that we discussed earlier, which include protections against things like sexual harassment. So, for example, Standard 1.9 and Standard 1.12 taken together require registrants to maintain professional boundaries and not abuse their position. These standards protect service users, carers, and colleagues from sexual harassment and other inappropriate behaviors in the workplace. All of these examples demonstrate what we mean when we say that EDI is a public safety concern. Using equality, diversity, and inclusion as a framework through which to consider and apply the standards in your practice can help ensure you are effectively meeting those standards. And when it comes to applying the standards, as I mentioned earlier, the standards of conduct, performance, and ethics are not prescriptive in that they do not set out exactly how you should meet them. They are outcome focused. And that means that what applying the EDI related standards looks like will differ not only between professions, but also for each individual. So, for example, if we look at Standard 1.5, treat people fairly and be aware of the potential impact that your personal values, biases, and beliefs may have, that might look like reflecting on how your personal values, biases, and beliefs may impact others. Or Standard 1.7, the requirement to raise concerns, that might look like familiarizing yourself with your local safeguarding procedures and your employer's policies for reporting concerns if you have an employer. In addition to these examples laid out on this slide, you might also undertake additional training or reading on EDI topics related to the needs of your service users. So now that we've talked a bit about what EDI is and what it means in a healthcare setting and how it relates to the HCPC standards, I'm going to hand over to Dabbi, who is going to talk more about EDI and his practice. Dabbi?
Hello, everyone, again. Thank you so much, Allison, for such a clear overview of our standards. I just want to briefly thank Becky Glass and the policy and communications team as well for inviting me here and trusting me with this platform. EDI covers such a huge spread and breadth of human differences, and my story really only covers a tiny fraction of that. So I'm very grateful for this opportunity, and hopefully I do it justice. So I've prepared some slides. So my name is Dabbi Taylor. I'm an occupational therapist, and I work in child and adolescent mental health in Glasgow. I'm also a HCPC Council Apprentice, and I come to all of this with my clinical training and with lived experience of early childhood trauma. I'm also neurodivergent and diagnosed with ADHD and substance abuse. So that last part is a coping part because of the previous two things I've just mentioned, and it's been on my mind a lot lately because last month marked 10 years of sobriety for me, something I'm very proud of, and I thought I'd share with you here today. So on the right there, you see me as a 3-year-old. I thought I'd add that there because for me it serves as a reminder to extend myself the same compassion that I try to extend to others, especially when talking about things like this. So I learned very early on in my life that vulnerability was a liability. So I had to learn to see myself through other people's eyes. So I had to edit what I would say, how I would present, and what I would let people see. And a lot of people call that masking. To me, it feels a little bit more complex than that because it really got to the point where I just lost my sense of self and my identity. And so I very actively have to practice staying in my own authenticity. So on the next slide, we have our standards again that Ali just brilliantly took us through. So the frameworks give us a certain framework, and they tell us what is required of us, and they become our anchor. But what I'm more interested in is what happens after that. So, because I think that the gap between our standards and between the people that actually benefit from those standards, I think the gap there is our culture. And there on the right, we see some of the factors that I think can contribute to that culture of EDI that we actively work towards. So the question I keep coming back to is, what are the conditions that make those results possible? And I believe one of those conditions is psychological safety. So I first encountered this term during a placement experience where its absence was just too impossible to ignore. And when I learned about it, I just couldn't stop thinking about it because these two words, they just explained such a huge part of my life. And when I delved into it, I came across the work of Amy Edmondson, and I take my understanding of it from her, who defines it as a belief that one will not be punished or humiliated for speaking up with ideas, questions, concerns, or mistakes, and that the team is safe for interpersonal risk-taking. Now, I'm taking some liberty here and I'm extending that definition to clinical one-to-one encounters because I believe that disclosure is indeed just that, an interpersonal risk. So all of that work has led me to develop what I'm calling just a simple mental model. And just a quick caveat here that this is my own working map. It's not an academic framework, and it's certainly not as linear as it looks either. It's just the simplest way that I've found to describe what I see happening through my own lived experience lens. So at the top there we have psychological safety, which is discussed as the environmental belief that the environment is safe to take a risk. And I think when that safety is there, or for me at least, vulnerability becomes more possible. And it's really in that vulnerability where I can authentically express my own needs. And what I think is often overlooked in this discourse is what happens after disclosure. So I've made recognition and action the key to meaningful participation, or what I'm calling there as thriving, is made possible. So I understand recognition as when something that's been shared is heard, it's been acknowledged, and something actually changes because of it. And that change can just be as small as being met with acceptance, rather than challenge or scrutiny, which is a daily reality for a lot of us. So when recognition is reliable, what we start to see is sustained participation. But when it isn't, I think that's when disclosure starts to feel a bit costly. I believe that's when we start to see more disengagement from our services. And I just want to give a short example of recognition in practice. So when I graduated, I did 2 interviews, both for the same job essentially, and both were asked for the same reasonable adjustment, which was to receive the interview questions in advance. This was because of my ADHD and how I process information under time pressure. So the first organization, they refused just outright, as is their right. The other one agreed, and all of the interviewees for that interview received the questions in advance. So in the first interview, I just completely bombed it. I ended up, the anxiety of processing the questions while trying to fill up the silence, while trying to answering them, just meant that I lost my sense of self, and I wasn't able to answer the questions to the best of my ability. In the second interview, we received the questions in advance, and I was able to use the time actually answering the questions rather than processing them. Today, I'm employed by that organization. I think it's an interesting example because it wasn't my capacity that changed between the 2 interviews, just the environment. So next, I want to share with you how all of this informs my own practice through what I'm calling 3 habits of practice. So the first habit is power. So my own lived experience has made me acutely attuned to power. So who has it? Where does it sit? And how is it? Or how can it impact? Or how does it affect my own chances? So I work in CAMS, and where I work with young people that have learned, I think very often correctly, that adults with authority are not always safe. So when a young person starts to avoid, or they start to resist, or go silent, my first question is not, what is driving this behavior, or what is wrong with them, or why are they acting like this, but rather, what in this environment has just communicated to them about whether it's actually safe to be here. And then I can start mitigating those factors. And that starts by noticing where control sits in the room, or power. And so that's just who's setting the pace, who's holding the agenda, and essentially who was this space built around. So the next slide, or the next habit of practice, I call borrowed assumptions. So I found out that my clinical assumptions and my personal assumptions are not as separate as I would have liked to believe. So I'm a white heterosexual male, and I grew up in an intensely male-dominated environment, which was very heavily influenced by outdated and often harmful patriarchal norms. Excuse me. And because of that, gender inequality was just largely invisible to me. And it wasn't until my younger sister, who I love and admire, started challenging me on those assumptions that I even began to examine them. And I think without her, a lot of those assumptions would have gone unexamined. And that part of me that I now like to call that fragile masculinity, it could have traveled with me into practice and potentially shaping what I notice, what I'm missing, and what I'm taking for granted. And that's what I mean by borrowed assumptions. It's the assumptions that we inherit from our culture and from our training, and that we carry with us into the room without realizing their impact. And I think the honest truth is that self-examination is never really guaranteed. For me, it really only happened because I had someone that I trusted and someone that I had given permission to push back on me. So I want to leave you with this question of, who is your sister or your brother Who in your life has that permission to challenge you on your assumptions? Now, after I've checked my own assumptions, the next thing I'm thinking about is, what does it cost to say all of this out loud? So when I think about the hidden cost of disclosure, I like to remind myself that before every disclosure, there's a certain calculation. And that calculation is, what are they going to think of me? Will this be used against me? Is it going to change how they see me or affect my credibility? So I try to remind myself to treat disclosure as a gift. It's not something that I'm entitled to, and it's definitely not something that comes without a cost. So in practice, what that really means is that consent is always ongoing. It means being aware of the power imbalance that disclosure creates. It means being explicit, very explicit about what happens after. So who's going to see it? Is it going to go in their notes? Is it going to come up in a multidisciplinary team meeting? Essentially, excuse me, essentially, what's going to change and what won't change. So this habit is particularly important to me because I know for my own part, and I've been a service user in services since I was 6 years old, and I have disengaged with services several times throughout my life, just because I didn't feel heard. And I don't want that for my clients or for the people that access our services. So I'm only going to spend a few seconds on this next slide. I think I've gone over time, and my apologies for that. So I won't read this out, but there's an accompanying blog that has these reflection prompts. We actually changed those first two prompts, and you can tell it's confusing giving this talk because I'm approaching it from that dual lens of a clinician and someone with lived experience. So those two won't be the same, but I encourage you to have a look because I think they're a good synthesis of what we talked about. Now, before I leave you, I mentioned at the start that I have lived experience of substance use. So that was actually the first time that I've ever shared that in an open professional forum like this. It was actually a real moment of vulnerability for me. So after this session, I would ask you to just take a brief moment and think about what were your assumptions about my credibility when I shared that with you, about whether I was safe to take seriously. Because I think that split-second judgment, that's what we've been talking about here. I think that's where EDI actually lives. It's in those consequences of being real, of being vulnerable, and being truly authentic to who you really are. Thank you very much, everyone. I'll now hand over back to Ali.
Thank you so much, Dabbi. Wow, that was really powerful. Thank you so much for sharing your reflections. I think hearing about both your own experiences, exactly as you said, kind of as a service user and as a healthcare professional, really brought to life the impact of equality, diversity, and inclusion, and really kind of, I think, demonstrated for everyone these kinds of considerations that we're talking about, and really what the standards might look like in practice. I think you also posed some really powerful and important questions that I think and hope that we'll all really take with us and think about over the next few days. So thank you again. So we're coming to the end of our session now, and I'm going to move on to signposting some useful resources and talk about some next steps. So there are a number of resources that you can access to support you in continuing to learn about EDI, to build on the knowledge that you've started developing today or that you've continued to develop today. I know quite a few of us in this session were kind of in the middle range in terms of knowledge about this topic. So really this is recommendations for you to continue that learning. So the HCPC has some great resources to help you think through, again, what the standards look like in practice. So those include our resources on person-centered care, raising concerns, and as I mentioned, the importance of reflective practice and reflecting on CPD. We have some reflective practice tools on our website as well. We also have some upcoming resources on supporting registrants who experience discrimination in workplace and education settings. So stay tuned over the next few months to learn more about that. You can also look to your professional body, your employer if you have one, or your trade union for resources, trainings, or more information. There is truly so much great information out there to support health and care workers on the topics of equality, diversity, and inclusion. And I really just recommend that you take just a few minutes, do a quick browser search, quickly look at your professional body, your employer's websites and resources that they have available. There is really a lot out there. So on your screen, we have some resources that the HCPC has to help you with your CPD, which is, of course, the reason that we're all here today, as it's CPD week. So all of these resources are on our website. You will receive the links in the follow-up email, or you can just browse the CPD section of our website. Again, your professional body can be an invaluable source of advice for resources. They are doing incredible work on CPD, on EDI, so definitely check out your professional body's website. And if you don't know who your professional body is, we have a list of all of the professional bodies on our website. So just search for HCPC professional bodies, and you'll be able to find yours based on your profession. And they'll produce material that is specific to your profession, and they can also provide some really great recommendations for you as well. So you can also contact them for more specific information. So we have some recommended next steps for you. We recommend that you take some time to reflect on your learning from this session. Hopefully you can think through some of the questions that Dabbi posed, some of the standards that we discussed, and how these might impact your practice and how you might want to really think through what those standards might look like for your service users. We encourage you to get involved in other CPD week sessions or activities. So attend another webinar. We have one final webinar tomorrow at the same time that you can register for on our website. You might set up a discussion with your colleagues about CPD. You might share your reflection on social media. If you do so, please use our hashtag here. And then we have more ideas on our website at this link here. So before you go, we do have a final Slido question. So now that we have gone through the session, we've learned about the standards, we've learned about EDI and healthcare, and Dabbi has shared his own experiences both as a clinician and as a service user. How would you rate your knowledge and understanding of EDI in your practice now? So I'll give just a few minutes. I know there's a little bit of a delay from when people vote to when the responses actually show up on screen. But already with around 30 votes, I can see that we're looking really strong. Just really excellent to see. That's awesome. That's looking really great. Thank you all so much for voting. I'm so glad to see that people have gotten a lot out of this session. And again, to keep learning more, you will receive these slides after the session with some more resources that we've just mentioned to continue your learning even after this session is over. So I'm going to go ahead and move on to our final slide, which is just to thank you so much for everyone who came along today. It was really great to have you here. We do have an evaluation form, so we'd really love to know what you thought about the session. It'll take no more than 2 minutes for you to complete, so you can either type the URL into your browser or you can follow the QR code there. Your feedback will help us improve our offerings for next time, next CPD week, or our next webinars. But there's also no rush. We'll send the link out in our follow-up email as well, so you can fill out the survey later as well. And we'll leave the screen up here for a few minutes before ending the session, just so that you can take down this information. But that is everything from me. So thank you all again, and I hope to see you all soon at another event.